Assalamualaikum warahmatullahi wabarakatuh and good evening to Excellencies, Professors, Doctors, ladies and gentlemen. It is my pleasure to be a moderator for this conference. I am Nurul Husna and on behalf of the organizing committee, I would like to welcome all of you to the second day of oral presentation of the Medicine and Health Sciences MHSC online conference. We appreciate you spend some of your time joining us today. As we have different fascinating topics to be presented on, we hope you will learn a lot and get more knowledge from this session. Just like yesterday, we will be having an oral presentation shortly, followed by a Q&A session between the judges and the presenters. To start, I am pleased to introduce our honorable judges for today's oral presentation. Professor Dr. Zulkifli bin Haji Yahya as the first judge and Professor Dr. Muhammad Jamil bin Yaakob as the second judge. Without wasting our time, let us begin with the first presenter, Dr. Normaizatul Afizah binti Ismail, with her presentation title, A Systematic Review on Vaccine Acceptance Rate in Malaysia.
Assalamualaikum warahmatullahi taala wabarakatuh, and a very good afternoon to all participants of MHS conference and honorable judges. I am Normaizatul binti Ismail, and my topic for presentation is a systematic review that I've done on vaccine acceptance rate in Malaysia. My presentation will include introduction, methodology, results, discussion, and conclusion. According to WHO, vaccination is recognized as an effective way to reduce and eliminate the burden of COVID-19. It means that vaccination is required to save life. So, following other countries' act, Malaysia also has started COVID-19 National Immunization Program since February 24th to February 2022. And within this duration, the government of Malaysia needs as many as possible citizens of Malaysia to be vaccinated. And we need to know that this program will only be successful when there is a high acceptance rate. Therefore, this study was conducted to assess the status of acceptance of this COVID-19 vaccine among the general population of Malaysia. For methodology, the first step was data sources and search. Database that I used were first the PubMed, Science Direct, and Google Scholar. I use Google Scholar because it covers a lot of publication type, not only confined to journal, but also includes magazine, books, and the result that was not captured by PubMed and Science Direct usually will appear in Google Scholar. The duration of the search was done from the 1st until the 14th of July 2021. For study selection, the inclusion criteria were first peer-reviewed published papers which evaluating COVID-19 vaccine acceptance using survey or questionnaire, and only studies in English language were eligible, and then the survey studies the Malaysian population. The exclusion criteria were the vice versa, which is the unpublished manuscript. The article did not aim to evaluate COVID-19 vaccine acceptance, and then the publication language was not English and the population was not Malaysian. To manage duplicate articles, Mendeley software was utilized. And for data extraction, systematic review was conducted using PRISMA guideline. This is a flowchart following PRISMA guideline. In identification stage, 260 articles were identified from 3 databases, and 55 duplicate articles were removed in Mendeley. It leaves 205 abstract or title to be screened. And after screening, then 198 irrelevant abstract or title were excluded, leaving me with only 7 articles. So full text were assessed for eligibility, and from here, 4 were excluded for not meeting the criteria. 3 of them were actually systematic review articles, which only cited the original article, and the other one was a survey conducted by Ministry of Health of Malaysia. Its acceptance rate was 67%, but the source were not available online. So in the end, the total studies included in synthesis were only 3 articles. So we move on to the results. Table 1 shows all the 3 articles that study COVID-19 vaccine acceptance rate in Malaysia. The first one is Wong et al. 2020, Said Alwi et al. 2021, and Valfi et al. 2021. I've arranged it in according to the time of data collections, where Wong et al. Have done it at the very early stage of the pandemic, somewhere in April 2020. Then followed by Said Alwi in December 2020 and Valfi also at about the same time frame. I need to highlight that all these 3 studies have collected data before COVID-19 immunization program started. We can see that Wong et al. And Said Alwi have covered a very big sample size of the general population of Malaysia, 1,159, 1,411, and the acceptance rate was very high, 94.3% and 83.3%. A lower acceptance rate was found in Valfi et al., but the target group were just residents of Penang that might not represent the whole population of Malaysia. Discussion. In Malaysia, the recorded acceptance rates was between 72 to 94.3%. And these high acceptance rates actually depends on several factors, such as age, race, marital status, monthly income, occupation, and medical condition. In comparison with other countries, Malaysia is at the same level as Ecuador, Indonesia, and China. Lower COVID-19 vaccine acceptance rate were reported in the Middle East, Russia, Africa, and several European countries. Another important aspect is about hesitancy and concerns about vaccine safety and effectiveness are the most common reasons behind refusal of COVID-19 vaccine. And there are some limitation to this study because in all these 3 studies, all of them use an online survey and it did not reach certain socio-demographic and illiterate group. So I'm afraid that the acceptance rates is actually lower than reported. As for conclusion, we found that Malaysia has a very high acceptance rates toward COVID-19 vaccine, which is 72% to 94.3%. And we need to address the reasons of COVID-19 vaccine hesitancy and build vaccine literacy, which recommended as further steps for making sure that national COVID-19 immunization program is a success. These are my references. And with that, I would like to thank all of you for listening.
Thank you, Dr. Normaizatul, for a mesmerizing presentation. Now, I would like to invite Dr. Normaizatul to proceed with the Q&A session with the judges.
I think before I proceed with the questions, I would like to congratulate you on the presentation. I think the strength of your presentation is the fact that you compare between the country of high and low acceptance rate. Yeah. But I think my question is, do you realize that it is important to include the study design of each studies, because there are differences between the cross-sectional study. If you take the patients who really want, and you ask them whether they really want it or not, or just based on memory, retrospective memory, definitely there will be a different. From the table I saw just now, there was no study design mentioned for each of the studies, okay, that's my questions.
Okay, Prof. Thank you for the question, Prof. To answer that question, in the results, the table that I've shown you is I prepared it according to the PICO guideline, meaning that I only put all the populations, intervention, comparisons, and outcome. But in terms of the study design, Prof, according to each of the study, some of them are using a different method, and I think I did not include that one because I think for the purpose of the presentation, actually, I cannot include everything in the table because I also exclude the outcome, actually the outcome part, which I supposed to put in my research, but I did not put in the table for the purpose of presentation because I cannot concise the table in one slide because I have to put a lot of outcome actually inside the table. But each of the study did mention.
You just need one column only to put the study design for each study.
Yeah, Prof. That one I did not manage to put that one. I think I missed that part. But I also actually did not put the outcome because of not enough of space actually.
Thank you to the presenter for answering the questions and for the great presentation. Next, we will continue with the second presentation, Challenges and Ways Combating COVID-19, Experiences from Universiti Islam Antarabangsa, Sultan Abdul Halim Shah, UniSHAMS, which will be presented by Professor Madya, Dr. Muhammad Faudzi bin Abdullah. Please welcome.
Bismillahirrahmanirrahim. Assalamualaikum. For my oral presentation today, my topic will be on challenges and ways combating COVID-19, experiences from Universiti Islam Antarabangsa, Sultan Abdul Halim Shah, UniSHAMS. Let us go beginning of COVID-19. That is 2 years ago on December 31. If you can see in the city of Wuhan, China, there is a cluster of pneumonia cases of unknown origin caused concern among the health officers. An alert note was issued by the Wuhan Municipal Health Commission, and subsequently a rapid response team was sent to Wuhan by the Chinese CDC. And as consequences of that, an immediate notification was made known to the World Health Organization. And on January 7, 2020, the causative pathogen was identified as novel coronavirus. And now that virus is known as 2019 nCoV, and the virus is distinct from both SARS-CoV and MERS-CoV, but yet they are closely related as sort like brothers sisters. Okay, early cases suggested that COVID-19 may be less severe than SARS and MERS. However, illness onset among rapidly increasing numbers of people and mounting evidence of human to human transmission suggests that 2019 nCoV is more contagious than both SARS-CoV and MERS-CoV. And on January 20, 2020, China's National Infectious Disease Law was amended to make 2019 novel coronavirus disease, that is COVID-19, as a Class B notifiable disease, and its frontier health and quarantine law was amended to support the COVID-19 outbreak response effort. On January 23rd, Chinese government began to limit movement of people in and out. And Wuhan announced its highest level of commitment and mobilized all sectors to respond to the epidemic in preventing further spread of COVID-19. As you know, the characterization of epidemiological features of COVID-19 is crucial for the development and implementation of effective control strategies of the infection. With the above COVID-19 pandemic chronology events, Malaysia is not exceptional and received her first wave of infection starting from 25th of January 2020, as reported in WHO portal, and a total of 22 cases were identified, of which 12 have a travel history to affected countries and regions. Let us look into the chronology. Let us look in the chronology in Malaysia. Started off, of course, by December 2019 as a pneumonia, as I've said earlier. And on the 25th of January 2020, first confirmed case in Malaysia involved 3 Chinese citizens. On the 31st of January 2020, WHO declares the coronavirus outbreak a global health emergency. On 12th of February 2020, WHO announces that COVID-19 is the official name for the 2019 novel coronavirus. 18 March 2020 is our MCO started in Malaysia. Is the first MCO is on the 18th of March, followed by the second phase of MCO on the 1st of April, and third phase of MCO on the 15th of April, and on the 24th of April 2020, government announces the permission for students to return home starting 27th of April. And the fourth phase of MCO is on the 29th of April, and followed by the fifth on the 13th May 2020, and on the 25th of May, completed the process of transporting local UniSHAMS students to return to their homes. And on the 16th of June 2020 is our sixth phase of MCO. So what happened in UniSHAMS? This is what happening in UniSHAMS. Operating and Preparedness Committee was formed. And what actually we do is that the management of UniSHAMS have been proactive by immediately forming an operational and preparedness committee during the announcements of the first MCO, as I was mentioned, on the 18th March 2020. And this committee is vital as a think tanker to coordinate the procedures and regulations during the MCO. This committee was formed at the university level and involved all category of staffing, inclusive clinicians, nurse, security and safety, student affairs and welfare. Everyone is involved, even the finance officer, to ensure that we have got money to support our student. Among the immediate actions that were taken by the committee includes liaising with the nearest health center. That is our klinik kesihatan, Kuala Ketir, and also our hospital baling, for COVID-19 treatment for all our student and our staff. Set up a call center, in the university for inquiries related to COVID-19, so that we don't have any panic among our student and also staff. Prepared protocol for triaging and evaluation of potential COVID-19 patients. Okay, we actually don't have any university, university medical center. So we need to liaise with our klinik kesihatan and the hospital baling. And if we find that hospital baling was unable to manage, probably will send our staff or student to our hospital Sungai Petani. Beside that, this committee also plays a role in equip hand sanitizer, personal protective equipments, that is the PPE, and also our temperature scanners to relevant departments. The closure of the university since the beginning of the MCO, that is in mid-March, 18th of March, remember, is undeniably an important public health measure taken by the government for the safety of students, staff, and the community. Dealing with uncertainty during the COVID-19 pandemic has had a significant effects on the students' physical and mental well-being. But anyway, university has in-house psychiatrists and counselors to help us, okay, to provide short-term professional counseling to students and staff who experience distress or anxiety related to pandemic. The university had made it a top priority to monitor the welfare of a stranded student on campus with the assistance of student council members and also staff from various departments. As such, university distribute food, free food, and also we had donations from the NGO to help, student and also probably staff who are in sufferings. Okay, concerning the students movement, students were restricted from entering and leaving campus except for emergency purposes, following SOP, which is prepared by the by the Ministry of Higher Education. Beside that, we also have preparation of hand sanitizer and also PPE. In the fight against COVID-19, the basic principle of infection control is to isolate the source and break the chain of infection. This is the basic of any infectious disease, any infectious pandemic or epidemic, okay? To break the chain of infection. In addition to training the university community of of social distancing, the proper technique for the use of alcohol-based hand sanitizer and the washings of hands with soap and water were also reinforced, together with the use of standard face masks provided by the university at that time, but not now. Okay? And then during this pandemic, the prices of hand sanitizer have risen with their limited supply. Hence, the university took proactive action by preparing in-house hand sanitizer in accordance with the WHO guideline. So our proactive, that is our pegawai science, we made and prepared an in-house hand sanitizer. The PPE, which includes N95 respirator, long sleeve insulation gowns, glove, and disposable face shields, are also limited in number. But we make it available, in particular to staff providing treatment and care for the potential COVID-19 patient, in preparation. Okay? Okay. Whereas for the sick or exposed student, what we do is that Students who have symptoms of influenza-like illness, ILI, such as fever and cough, are of course isolated in an isolation room, okay, and taken after that to the nearest health clinic for further management. This process will require a full PPE driver and a van with windows open to minimize the risk of transmission to the person who drive the sick student or staff. Okay, the sanitation process will be carried out on the driver involved and the transport used immediately after the sending of the student or the sick staff. Okay, and between the 18th of March and the 10th of June 2020, we found that there is no student or staff was identified with COVID-19 positive. Alhamdulillah. This is a process of returning home of our student, once the government allow them to go back. And Ministry of Higher Education announced permissions for students to return to their home by following the SOP on the 24th of April 2020. So, the procedure for transporting students was strictly monitored by the MKN and also by our MOHE. Okay, what we do is that the health declaration form has been filled out by the student to confirm that they have no influenza-like symptom and they are in good condition to return home, so that they don't bring COVID-19 back to their home place. Okay. Okay. Beside that, we also offer liaison officers, whereby these liaison officers accompany the student on the bus until they reach their destination. And mind you, where do we send? These officers were responsible for monitoring the student to follow social distances and also to comply with the use of face mask and hand sanitizer, and the passing of the student to their parent took place only at the Ibu Pejabat Polis Daerah, that is the IPD, okay, following the SOP. You see how concerns are the university, the liaison officer, ensuring the safety of the student. We accompany them in buses, ensures the strict SOP in the buses, and then we send to the nearest IPD, and the parents come and pick them up to ensure safety to back home to their destination. Okay. Moving forward, this unprecedented global crisis has caused significant impact on various sectors, including educational sectors. As you can see, what we are doing right now, we are all having online lectures, online practical, and everything is online. You see, significantly impact, okay, not only on educational but also on our economic. Okay, it has changed many traditions and daily life routines, leading us to live in a new norms. Okay, cases of people infected with COVID-19 are still being reported until today. Hence cause UniSHAMS to always be prepared and put the priority on safety and hygiene aspect for the benefits of everyone. Beside that, and now if you can see, we are the first university to offer PPP Awam to our community. It was launched yesterday. It was launched on the 1st of August, and we are very happy that many crowds came over to UniSHAM at our Cypher building to ensure they have their vaccination. I think that is the only ways that we can make close UniSHAM staff and student to our own community that is area around Baling. I think that is a very good move by our UniSHAM. With that, ladies and gentlemen, I end up my oral presentation. These are my references from 1 to 14. Thank you.
Another astonishing presentation we had just now. Now again, I would like to welcome Professor Madya, Dr. Muhammad Faudzi to begin the Q&A session.
to have your comment on, because your topic title is Challenges and Ways Combating COVID-19, and you give the example in Wuhan. Do you compare with Wuhan, the techniques over there with the techniques over here? Because, and you give a long introduction.
Okay, Assalamualaikum warahmatullahi wabarakatuh. For your information, I just took you all into memory lane. 2 years ago, it was started doing Wuhan, in Wuhan, China. So I took you all throughout the lane so that you have the, you have the picture, of the chronology of what happened during COVID-19. I'm not comparing actually what actually happened during COVID-19, starting from Wuhan, China, until our university takes, action for what is happening for the pandemic. That is the scenario actually.
Okay, thank you.
Okay, I would like to congratulate the presenter for listing out the steps taken by UniSHAMS in handling COVID-19 among the students especially and staff. My comment is, you in the topic you mentioned about challenges and ways combating COVID-19 in UniSHAMS, but when in the presentation you only mentioned the ways you have listed. For example, from the beginning you mentioned about setting up the committee. Basically, setting up the committee is the solution, the ways, but what are the challenges basically? So as a panel, we are looking at few challenges. For example, if I were to give example, why committee was set up, perhaps because the challenges is COVID-19 is the public health emergency. So when you talk about challenges and ways of combating, you start with what are the challenges. The challenges are, we are dealing with COVID-19, which is a public health emergency. As a result of that challenges, then you have to set up a committee. So setting up a committee is a solution to the public health emergency that is threatening to people as well as UniSHAMS. So there are many other examples where you have listed very well about the solution, but not the challenges. That is my comment. Thank you.
The challenges is that we are ensuring that we don't have any case of COVID-19 in our university. That is why we are very proactive. In fact, if we have any case, for example, we have one of the case from our international lecturer who was positive when he was about to go back. So there were five of them. When they did the PCR testing. It seems that only 2 of them were able to go back, and the 3 of them have got to come back home, in Taman Insania for them to be quarantined first. So I think we have done a very proactive, challenge for that, in a way that we managed to ensure that the infection was not spread in the university. I think we have done quite good coordination with our clinic kesihatan and also our CAC to ensure that they will come and do the monitoring when we do the home quarantine for the 3 of the family members of the international lecturer.
Okay,
I think that is a challenge,
yeah, but having no cases are the outcome, meaning good outcome, positive outcome. It is not a challenges. The challenges is what are the problem basically, that you need to solve. Problem like, for example, I give another example. For example, when you mentioned about the need to communicate, why you need to communicate, maybe you can say that the challenges is that the university is so big and the students are so diverse, and you need a form of united channel of communication. That is the challenges, and because of that you need to form a good communication, you see.
Okay.
Thank you, judges and presenter. We will now proceed with our third presenter, Nurshafarina binti Shaari, with her presentation titled Depression Among MBBS Students of a Medical School in Malaysia.
Assalamualaikum and a very good afternoon to our respected judges and all the participants of Medicine and Health Sciences Conference 2021. My name is Nurshafarina binti Shaari and I would like to present on the topic of depression among MBBS students of a medical school in Malaysia. So a little bit of background study. The quality of life as defined by the World Health Organization is as an individual's perception of their position in life in the context of the culture and value system in which they live and in relation to their goals, expectations, standards and concerns. Quality of life included four multiple aspects which are psychological health, physical well-being, social relationships and environmental conditions. Even though most health professionals were trained on attending to this aspect of their studies, their own quality of life might decline during their years in the medical school. Many studies have reported there's decrease in quality of life scores among medical students during their training years. Okay. The various stresses might influence the quality of life of medical students, such as stressful transition from basic to clinical years, continuous demands when interacting with patients, peer competition for academic excellence, the overwhelming load of new information to learn on a daily basis, and of course the difficulty to balance academic duties with daily life activities. Poor quality of life among medical students is also associated with unhealthy lifestyle, psychological distress, and academic failure, which could affect their care for patients in the future. Thus, assessing the quality of life of medical students allow for better understanding of their general condition and thus can guide administrations towards specific, more context-sensitive and appropriate interventions to promote students' quality of life. Therefore, in this study, we aim to determine the prevalence of anxiety and depression of medical students and to assess their quality of life. So the methodology that we are going to use in this study, the methodology that we use in this study is cross-sectional study, involve 84 medical students from UniSHAMS. We use hospital anxiety and depression scale as a tool. It is a validated questionnaire that has total of 14 items divided into two subscales, which is our anxiety subscale and depression subscale. A score of 0 to 7 will indicate the absence of symptoms or anxiety, while score of 8 to 10 will indicate presence of symptoms. Meanwhile, score of 11 or greater indicates significant symptoms. Another tool that we are going to use to assess the quality of life is a questionnaire validated by the WHO itself. It's QOL-BREF. It's a questionnaire that total of 26 questions that can assess the four domains of quality of life, which are physical health, psychological domains, social domain, and environmental domain. A little bit of literature review on these topics. So the depression among medical students has increasingly become a concern for medical educators globally. In a recent research, up to 27.2% of medical students had depression globally. Research found out that depression affects about a third of medical students worldwide. So the major factors could be burnout and academic performance. So what is burnout? Burnout is a state of physical emotion and mental exhaustion. So in a study conducted on USM medical students, it shows that 67.9% of their students experiences burnout. The academic life of medical students can be considered as the major source of stress. As for academic performance, medical education they are very demanding and require intensive environmental of medical excessive pressures. The source of stress are linked with medical training and are relatedly particularly to academic requirements. Yeah, as shown in this study, where they use DAS as a tool, students who passed had significantly lower symptoms of stress, anxiety, and depression than those who failed during the examination period. So now we will talk about the effects of mental health, depression, anxiety on the academic performance of the students. Okay, when the research by Community Health of Family Medicine in University of Florida, when calculated the GPA of a students, medical students with depression have lower GPA, can cause by lack of interpersonal communication skills, enthusiasm, and recognition. Thus, it leads to lower academic performance. Now we are moving on to the effects of anxiety and depression on the behavior and social of a medical student. When a student is diagnosed, when the student has depression or anxiety, he or she will exhibit low emotional care, low self-esteem, and unstable emotions. This will lead to suicidal thoughts, high alcoholic consumption, anger and aggressiveness, and also extra anxiousness. The effects of anxiety and depression on academic performance, it can also be caused by the changes in sleep patterns for a student with depression. So this will, the type of sleep patterns can be insomnia, excessive sleepiness, or restless sleeps. Okay, this has take a toll on their physical health. They can cause fatigue, headache, and will affect on their study time and assignment completion. Students who have depression also are have low mental strength that can lead to that have a tendency to they have tendency for suicidal attempts. They also have a tendency to be more delusional, out of focus, and unwilling to do things within their unconsciousness. They also can lead to sad, emptiness, hopeless, uncontrolled behavior, and uncontrolled sexual behavior, drugs intakes, and smoking. So the prevalence of depression amongst medical students in preclinical years showed by various studies that they are more depressed in preclinical years than the clinical years. These are the most common active coping strategies used by most medical students and in a study in Management and Science University in Malaysia. It's the active coping, religious coping, positive reframing, acceptance, denial, self-blame, alcohol, or substance use. So as for this current study, a total of 84 students have participated in this study. The prevalence rates of anxiety and depression were 33% and 11% respectively. Female students showed lower psychological score. Anxiety and depression were associated with significantly poorer quality of life. Students with depression symptoms were associated with lower physical, psychological, environmental domain score, whereas those with anxiety had lower psychological, social, and environmental scores. Overall, the quality of life score was significantly lower in female students and those with depression. So to conclude my presentation today, although the prevalence of anxiety and depression symptoms is not as high as what reported in most of the Asian countries, it is still vital that the relevant stakeholders, such as medical schools and hospitals, to be aware of this psychological stress that the students may be experiencing. In addition, these students had demonstrated that the psychological symptoms affects the students' quality life as well as their academic performance. Mentorship programs are believed can be useful in helping students. In addition, there are also several studies which demonstrated that mindfulness training may be effective in increasing students' resilience and reduce psychological stress. In conclusion, this study confirmed that QOL of medical students are affected by anxiety and depression, and further highlights the importance of medical school to develop strategies to identify students at risk of mental stress and to perhaps improve the current support system for students. With that, thank you.
Thank you to the presenter for the appealing presentation. Now, I would like to invite Nurshafarina to start the Q&A session.
Right, your topic on depression among MBBS students, but you mentioned also anxiety in your conclusion. Right, is there any relationship between anxiety and depression?
Assalamualaikum to both judges and members on the floor. Thank you for the question, Prof. Zul. Anxiety is usually a precedent to depression, Prof. I hope that answers your question.
No, my question is you come to the conclusion anxiety. I just want to know, is there any study done to relate the relation to correlate anxiety and depression in your study?
No. The questionnaire addressed anxiety and depression separately.
Okay, thank you.
Congratulations, Dr. Ms. Shafarina, for your excellent presentation. I have a few questions. Before I give my questions, can I ask you what are the objectives of the study again?
We would like to assess the prevalence of anxiety and depression among our medical students, and also to see how it affects their quality of life.
Oh, I see. Okay, I was in fact looking at the association between anxiety depression score with poorer quality of life. Yeah, and I'm not sure whether when you presented about the effects on academic, the effect on behavior, and the coping style, was it considered as the quality of life?
That's because quality of life there includes 4 domains.
Okay.
The domains include physical health, psychological domains, social domains, and environmental domains.
So the effect on academic and effect on behavior comes under which domain? And also the coping strategies.
That would come under social domain, social and behavior domain.
Okay. All right then. I think I have no further questions.
Thank you to the presenter. I hope that answers the questions. Last but not least, let's continue with the last presentation, EXFOME, the first exercise clinic with primary health concept in Malaysia at UniSHAMS through a smart partnership with Ministry of Health and Asia College of Medicine by Professor Madya, Dr. Omar bin Mihat.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Alhamdulillahirabbil alamin. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatam min lisani yafqahu qawli. Good morning everybody. Actually, I'm Dr. Omar from UniSHAMS. I would like to present my presentation today. The title is EXFOME, that means exercise for medicine. This is the first exercise clinic with primary healthcare concept in Malaysia at UniSHAMS. That is through a smart partnership between Ministry of Health Malaysia and the MS New Symphony. As an introduction, as we know, physical activity and exercise intervention is part of NCD prevention. And EXFOME, that means exercise for medicine, is the only high-risk approach available so far. Because in public health, we have two strategies, population strategies and high-risk approach strategies. Population strategies is just like you ask somebody to perform exercise, to do aerobic, but EXFOME is specific to everybody, specific to those who are being selected. I mean, that is the only high-risk approach available in terms of exercise in NCD prevention. And of course, this EXFOME really benefit, especially those in the category of borderline. That means pre-diabetics and pre-hypertension. Why? Because pre-diabetic and pre-hypertension, as we know, there is no what you call, it's not necessary to use the drug. We can use non-pharmacological intervention. That's why using exercise, inshallah, I think we can convert pre-diabetic and pre-hypertension back to normal, as we will see soon. Hence, of course, this will reduce the incidence of diabetes and high blood pressure or hypertension in Malaysia, and in long run will save the country's financial burden. That is the burden of treatment of the non-communicable disease. Okay, let's see the prevalence of a few non-communicable disease in Malaysia. That is our NCD's statistic. If you look at diabetes and hypertension, in 1996 National Health Morbidity Survey for diabetics is 8.3, the prevalent. If we compare now, National Health Morbidity Survey, the latest is 2015, it has increased double-fold, 8.3% to 17.5%. And moreover, the undiagnosed diabetes is also increased from 1.8% to 9.2%. And if you look at the hypertension, it also increased from 29.9, now it's almost 30.3%, while the undiagnosed hypertension in 2011 is 19.8, now is 17.2%. If we look at these two statistics, diabetes and hypertension, surely we have to find some way in order to reduce this prevalence as well as to save the country budgets. Okay, from there we can start. We start to have a smart partnership in order to to consolidate our efforts. This smart partnership is composed of UniSHAMS, MS New Symphony and Kementerian Kesihatan Malaysia, that means Ministry of Health, in setting up exercise clinic for the purpose of preventing the incidence of NCDs by focusing on pre-diabetic and pre-hypertension. Because we focus this pre-diabetic and pre-hypertension because if you can convert pre-diabetic and pre-hypertension back to normal, you can save the treatment cost for both these particular diseases. Okay, let's see the justification why we three of this partnership working together. First, we know that NCD can be prevented. Of course, stage pre-diabetic and pre-hypertension is reversible through exercise. Secondly, we encourage the exercise activity among the populations. And of course, the most important one is intervention by exercise prescription. This is the only available prescription in the form of exercise for treatment of, to reverse the pre-diabetic and the pre-hypertension. Okay, in our smart partnership, every partners, they have a roles. We have already agreed. First of all, International Islamic University of Sultan Abdul Halim, or UniSHAMS, will provide the facility. The exercise clinic is placed at the ground floor of the medical faculty of UniSHAMS. Then we provide health counseling, consultation for the clients, while Ministry of Health Malaysia, that is from Kuala Ketil Community Health Clinics, will identify the clients who have the selected NCD risk, that is pre-diabetic, pre-hypertension, obese, and refer them to the exercise clinic for follow-up. Also provide the service of what you call the lab service, in order to screen all the patient or the clients. And then the clinic will work hand in hand with the exercise therapy in the exercise clinic, so that they can work together in order to manage the patient. While the MS New Symphony will provide exercise therapists, which are graduated from Asia College of Exercise and Sport Medicine, ASEM. Secondly, the exercise therapists from ASEM were trained with the aim to control and to treat non-communicable disease such as pre-hypertension, pre-diabetic, obesity, dyslipidemia through the right dosage of exercise. The word here is dosage of exercise, because it is specific to individual. Each particular client will have their own dosage accordingly. In this tripartite program, MS New Symphony also provide the equipment and the expertise to deliver and train the client referred to them. This is the overall, the bird's eye view, how this tripartite program works. First of all, of course, the pre-diabetic and pre-hypertension and obesity was selected from Kuala Ketil Health Clinic, and then this is the entry point, referred to from the health clinic and walk-in client to the exercise clinic at UniSHAMS. Of course, the exclusion criteria will be those who are pregnant and disabled. If you look at this flow, this is how the clinic works. The exercise clinic, the exercise therapy, we receive the patient from the doctor at the health clinics. Most probably the most important one to be referred is the pre-diabetic and pre-hypertension, because this condition is reversible. And then after that, the assessment and the testing protocol will be done by the exercise therapy. Exercise therapy will assess patient body fat, fitness level, and then prescribe CER accordingly to the condition customers. CER I will explain later on. ET will personally train the patient and then review every 3 weeks, refer patient back 3 to 6 months to the clinic, and then the E3 will provide the doctor with the reports, comparison on the body fat and fitness level, as well as the development of the hypertension and the blood sugar. What is CER just now is customized exercise regime. Exercise should be customized to a specific individual following a scientific protocol of assessment to determine the current status of the person in all the components of fitness definition. Thus, CER will address the deteriorated component accurately, ensuring a progressive progress. Contrary to the conventional use of physical activity, conventional physical activity such as leisure and sport activity, there is no dosage response profile, and that can trigger the adaptation to treat the specific disease. Instead, in that particular leisure, sometimes there were events of sudden death and many injuries sustained from overuse and from overexertion. Okay, that's how the exercise at UniSHAMS works. As I mentioned before, the assessment by the exercise therapy will include they will assess the body fat, the fitness level, and prescribe the exercise prescription according to customized exercise regime. And then if we look at the apparatus or the equipment which is being used for the assessment, they call it physical fitness assessment, PFA. The first one is the 3-minute step-up test for cardiovascular fitness. I mean, the client has to step up for 3 minutes. Step-up test, we call it for step-up test. The second physical PFA is 1 minute push-up for upper body strength and endurance. And then the next PFA is 1 minute sit-up for abdominal and trunk endurance. And then followed by the next PFA, sit and reach. This one will measure the flexibility of the particular client. And finally, we get the skin fold for the percentage of the body fat. All the result of all this PFA will be key in the computer. They call it a special software, Dr. Fits, and then this software will churn up this particular information and come out with the regime, with the exercise regime, with the doses as well as the frequencies. Okay, these are the set of gymnasium which are being used in this exercise clinic. First, the treadmill, then the dumbbells and sandbags, then gymnasium balls, static cycle, and wall pulley with weight. These are equipment which has been set up in the exercise clinic. These are the overview of physical fitness test exercise. First, sit-up test. That means you have to to try to extend your hand as far as possible. Then checking the heart rate, then step up test. You have to go up the step, and then sit and reach. And finally, we can what you call proceed with the cycling and treadmill in terms of what you call doing the exercise according to the dosage frequency which has been prescribed by the Dr. Fitz. Okay, regarding the result, actually there was a pilot project began in September 2012 which involved Asia College of Sport Medicine and Ministry of Health, and a few states in Malaysia have been involved. That means Selangor, Negeri Sembilan, and Jawa Wilayah Persekutuan. And following that, a few health clinics has been set up, has been what you call selected. In Selangor, KK Puchong, Shah Alam, Section 7, Shah Alam, KK Bangi, KK Sungai Chua, Negeri Sembilan, KK Seremban, Wilayah Persekutuan, KK Prison 3. And overall, these are the clients which have been what you call enrolled in the pilot project. They divide into agreed and disagreed, because when we screen the patient and get the result, if the patient is pre-diabetic or pre-hypertension, we will ask the patient whether they agree to join the pilot project or not. Finally, we found that 57 disagree. Among them is pre-diabetic 36, pre-hypertension is 24, and overweight is 47, and 134 agree. There have been pre-diabetic 52 clients, obesity 103 clients, dyslipidemia 54, pre-hypertension is 65 clients. And around this, among this, when those who met the criteria and being registered is 181, and then they have all this particular what you call client will be intervened during the using the what you call the exercise regime CER, which has been described before. And then in short, the result of the pilot project among the clients who involved, percentage of clients achieving optimum level in selected parameter after 6 months is highest for those pre-hypertension. That means pre-hypertension 56.8% achieved the normal blood pressure, while pre-diabetic 34.3% achieved the normal blood sugar. Overweight and obesity has reduced to normal 30% of them, while body fat have improved 28.8%. But dyslipidemia only record 9.1% success. And overall physical fitness has been improved of 57.9%. That means overall achievement of those who receive the normal level of parameter studied among those given prescription is very what you call prominent in hypertension. Nearly more than 50% has achieved the normal blood pressure. While our smart partnership program, of course, due to the COVID-19, there was a disturbance, and of course we have to stop our service Anyway, for this smart partnership program between August 2009 and September 2020, total recruitment is 104 clients, and discharge after 6 to 9 months. That means those who have completed, they have received. That means the BP has become normal, as well as the blood pressure, the blood sugar become normal. 7 clients has been discharged. 2 obesity and 5 pre-hypertension. They have what you call achieved the normal blood pressure. And then refer back to the doctor is 5 clients, or refer back for further investigation and treatment. And the group of client pre-hypertension is 21, obesity is 53, and pre-diabetic is 7. And we have to what we call we have to stop temporarily this program due to COVID-19 and the strict PKP procedures. Anyway, lot of good values which has been what you call achieved from this particular smart partnership. We know that exercise program to expand coverage for treatment and play the role in disease prevention of NCD, because through this program we can save the government monies, and of course will increase the knowledge and as well as the skill of ET in managing the clients. And of course the blue ocean strategy, of course being optimized in terms of this particular smart project. Okay, there are a lot of challenges faced for the success of this program. First of all, we have to look into the defaulters, time factor, logistic reason, family commitment, or unable to sustain changes in behavior. Then pandemic, of course, movement control order period, which has what you call caused a lot of convenience for this particular program. And then lack of motivation, we have to due to disrupted cycle, session of appointment and so on, and health clinic limited manpower due to pandemic commitment. And finally, of course, we are trying our best. If the PKP ended, we can continue this program as usual, and we hope that this program will provide what we call the best management, as well as will be a great leaps in NCD prevention, especially in the high risk strategy. Sekian, thank you very much, and hope that we can what we call proceed further in terms of continuing this exercise clinic. Thank you.
Thank you, Professor Madya, Dr. Omar, for the impressive presentation. I would like to invite Prof to answer the questions from the judges.
Thank you, Dr. Omar. Right, I will ask you a question. You give us the pilot projects. I do not know where are the pilot projects, and the result. You try to relate with your result with your study in UniSHAMS.
Okay, can you hear me? Saya dengar. Assalamualaikum warahmatullahi wabarakatuh. Actually, regarding the pilot project is while I was in the ministry, this program exercise for medicine or prescription exercise has been what you call launched, and we together with SPA College have selected what I've mentioned before, because this is a long story. And finally, of course, due to the lack of posts in the klinik kesihatan, we cannot proceed this particular program because we need a ET post at the klinik kesihatan in order to become a counselor. Before actually we have already tried to send what they call to the JPA extra post or required post for this exercise therapist, but it was rejected. And of course, discontinuing this program, the Smart Partnership, is to my idea so that we can continue this program and show the effectiveness of this exercise exercise prescription, and hoping that we can get some data from this, and then we can get the post to be approved at the klinik kesihatan. That's the whole story lah.
Thank you, Prof. Omar. I think thank you for the presentation, very elaborate presentation. My comment is that this is a very ambitious and over-inclusive presentation where you try to describe the activity of the clinic and perhaps come out with conclusion. Sometimes it's hard for us to decide, when we compare between the descriptive presentation with other studies, because this is more of a narrative, a descriptive kind of presentation. This is not a questions, but rather a comment which might be used in later presentation by other candidate. Perhaps when we give oral presentation 8 minutes, the time will tell us already that we have to identify issues, questions or concern regarding the activity. Perhaps it is more easier for us to compare with other study if you compare or you identify issues in the first exercise clinic and suggest any new ideas or critically appraise the program of exercise clinic. Okay, so this is just a comment, not a questions. Thank you.
Okay, pertaining to the comment, actually, what is going on in our university? Actually, it is ongoing research. Actually, the patient itself has been what they call intervene and follow up, and then we are hoping that we will proceed with what we call a certain success especially in converting pre-hypertension to normal and pre-diabetic to normal. Even we maintain pre-hypertension also, it's mean a success because we don't require treatment for pre-hypertension and pre-diabetes. But unfortunately, we have to stop this program because of the COVID. That is the uncertainty lah. Anyway, we are hoping that after what you call COVID has settled down, maybe we can operate this clinic so that we can continue the ongoing research coming. I mean, the patient is being referred, and because just now we mentioned only a few have been converted normal. That is within the 6 to 9 month period. And the patient, the client joined continuously, not necessarily 2 years ago. Sometime maybe some of them maybe 2 months, maybe 3 months, maybe 6 months, and so on. And we are hoping that the COVID-19 will settle down so that we can continue this ongoing research. Thank you very much for the advice.
That are the challenges.
Yeah, thank you.
Thank you, Professor Madya, Dr. Omar, and also the judges. With this, I conclude that our session for today has come to an end. I believe that our audience were captivated by all of the presentations just now. Thank you to all presenters for the excellent presentation. And not to forget, thank you to our today's judges, Professor Dr. Zulkifli and Professor Dr. Muhammad Jamil bin Yaakob, and all audience for attending today's oral presentation of the MHSC online conference. Once again, thank you to everyone. Stay healthy and stay safe. Assalamualaikum warahmatullahi wabarakatuh and goodbye.